जी डॉक्टर साहब, आपका शाल चैनल में बहुत बहुत स्वागत है।
Thank you very much for inviting me and talking to me.
आज ईवान हॉस्पिटल का जो आपने यहाँ पे कार्यक्रम रखा है, तो आज किस तरीके का आपने जो जानकारी दी, सभी डॉक्टर्स लोग यहाँ पर मौजूद हैं, क्या था पूरा कार्यक्रम?
हमारा पर्पज़ था कि यहाँ पर हम जो पूरी जो IMA की जो टीम है मुजफ्फरनगर की, उनको हम अवगत कराएं कि हमारे ईवान में आज सभी प्रकार के डॉक्टर अवेलेबल हैं। आज कोई चीज़ ऐसी नहीं है मुजफ्फरनगर में जिसके लिए लोगों को मेरठ दिल्ली जाने की ज़रूरत पड़े। हमारे पास हर तरह की फैकल्टी यहाँ पर अवेलेबल है।
जैसे कि आज यहाँ पे स्पाइन के और फिजियोथेरेपी के जो डॉक्टर यहाँ पर बाहर से भी आए हैं, तो क्या ईवान में इस तरह की भी आगे सुविधाएं मिलेंगी?
ईवान में जो डॉक्टर यहाँ पे स्पीकर थे वो सब ईवान के डॉक्टर हैं। आज ईवान में चाहे वो कार्डियो है, चाहे वो आर्थोपेडिक है, चाहे वो नेफ्रो है, चाहे वो गैस्ट्रो है, चाहे वो OT है, गायनी है, रेडियोलॉजी है, सभी प्रकार के डॉक्टर आज ईवान में अवेलेबल है 24 घंटे। इसके लिए किसी को कहीं पे जाने की ज़रूरत नहीं है, केवल ईवान में 24 घंटे ICU, CCU, इमरजेंसी रूम, OP होती है।
आज डॉक्टर साहब एक चीज़ और सबसे मेन आ जाती है कि जिस तरीके इस महंगाई के दौर डॉक्टरों से बहुत ज़्यादा लोग डिस्टर्ब भी हैं, तो क्या ईवान में कुछ जो लोग इस लायक नहीं है, अपना ट्रीटमेंट नहीं करा पा रहे हैं, अगर वो लोग आप तक पहुँचेंगे, क्या उनके लिए कोई सुविधाएँ हैं?
ये आपने बहुत अच्छा क्वेश्चन पूछा। आपको मैंने 3 साल पहले जब मैंने ईवान को टेक ओवर करा था, तो मैंने 5 वादे मुजफ्फरनगर के वासियों से करे थे। बेस्ट हॉस्पिटल, बेस्ट डॉक्टर्स, बेस्ट इलाज, बेस्ट मेडिसिन एंड कम दाम। तो आज ईवान में मैं गरीब आदमियों का भी इलाज कर रहा हूँ और फ्री भी इलाज कर रहा हूँ। जो लोग पैसे देने में समर्थ नहीं है, उनको भी मैं देख रहा हूँ। इसके अलावा हमारे पास आयुष्मान की भी प्रोग्राम है, जिसमें आयुष्मान में हम पेशेंट का ट्रीटमेंट कर रहे हैं। यदि कोई बहन भाई मेरे मुजफ्फरनगर का है और वो बिल्कुल पैसे देने में असमर्थ है और जेन्युइन है, मैं उसकी हेल्प करने के लिए तैयार हूँ।
बड़ी बात है डॉक्टर साहब, आपने ये चीज़ जो आपने कही है, क्योंकि मुजफ्फरनगर में खास करके इस चीज़ पर आपने जो ध्यान दिया है, कहीं ना कहीं उन लोगों का ट्रीटमेंट हो पाएगा जो लोग वहाँ तक पहुँच नहीं पाते। तो ईमान की तरफ से आपने जो ये सरप्राइज़ है लोगों के लिए, और जो पहले से आपने कहा करी थी, अब आगे जो जो रणनीतियाँ हैं, मतलब आपके यहाँ पे जैसे कि गायनो डॉक्टर है, उनकी भी क्या फैसिलिटी मिलेगी?
हमारे यहाँ गायनों की है, गायनी डॉक्टर है हमारे पास। हमारे पास सभी प्रकार के डॉक्टर हैं। ये सब ईवान के एम्प्लॉई हैं। 99% डॉक्टर्स ईवान के स्टाफ हैं, ये आउटसाइड स्टाफ नहीं है, ईवान के स्टाफ हैं। तो मेरा लक्ष्य है कि मैं अपने ईवान के अंदर सभी प्रकार की सुविधाएं आपको दे सकूं और मेरे मुजफ्फरनगर के वासियों को दे सकूं कम से कम दाम पे। मेरा लक्ष्य पैसे कमाने का नहीं है, ना मैं पैसे कमाने के लिए यहाँ पे आया हूँ। मेरा एक ही लक्ष्य है कि मैं मुजफ्फरनगर वासियों को, और जो मेरा ये वतन है, मेरा ये मुजफ्फरनगर शहर है, ये मेरा परिवार है, पूरा मुजफ्फरनगर मेरा परिवार है, उसको मैं हेल्प करने के लिए अमेरिका से हर दूसरे महीने यहाँ पे आता हूँ, ताकि ईवान 24 घंटे मेडिकल सुविधाएं प्रदान कर सके।
जैसे डॉक्टर साहब बीच में डिस्टर्ब हो गया तो पेशेंट उससे भी काफ़ी डिस्टर्ब हो गए हैं, तो आगे से इस तरह की कोई कंडीशन होगी, क्योंकि काफ़ी ईवान से लोगों का जुड़ा हो गया था। दूसरे हॉस्पिटल तो बाद में ही जो आज चर्चाओं में है, लेकिन ईवान ने एक नाम कमाया, लेकिन उसके बाद में जो थोड़ा सा बीच में रुकावट आई, तो उससे कहीं ना कहीं जो आपके पेशेंट थे उनमें परेशानी तो पैदा हुई।
मेरे को नहीं समझ में आया कि जब से मैंने लिया है कि 4 साल होने को आ रहे हैं, कि इस बीच में कहीं भी हमारे पे रुकावट आई।
नहीं इस बीच, हाँ वो 4 साल आपके पीरियड
हमारे पीरियड में कभी रुकावट नहीं आई। पहले फाइनेंशियल रीज़न की वजह से जो हमारे डॉक्टर भाई बहन थे, उनको फाइनेंशियली लॉस हुआ था। लेकिन जब से मैं चला रहा हूँ, भगवान का आशीर्वाद है, सब चीज़ ठीक चल रही है, लोगों की सेवाएं हो रही हैं। इसी प्रकार से हम यहाँ पर सभी प्रकार के डॉक्टर ला सक पाए हैं। आज ईवान एक ऐसी इंस्टीट्यूशन है मेडिकल में, जिसमें हर तरह का डॉक्टर अवेलेबल है। ईवान से बड़ा कोई हॉस्पिटल नहीं है, यहाँ तक कि जो सिविल हॉस्पिटल है, जिसको हम बड़ा अस्पताल बोलते हैं, उसमें भी सब तरह के डॉक्टर अवेलेबल नहीं है जो ईवान में है। और यहाँ पे 24 घंटे सेवाएं उपलब्ध हैं। आईसीयू ओपन है, सीसीयू ओपन है, इमरजेंसी ओपन है। एक ईवानी ऐसी फैसिलिटी है जिसमें हम 24 घंटे ट्रामा सेंटर की ट्रामा की भी सेवाएं दे सकते हैं।
डॉक्टर साहब थैंक यू, आपने शार्ट में समय दिया है।
यू वेलकम सर। मेरा प्राउड है, मेरे को तो ये खुशी की बात है कि मैं अपने देश के लिए, अपने शहर के लिए कुछ कर सकूं और अपने भाई बहनों के लिए कुछ कर सकूं। इसी वजह से मैं यहाँ पे आता हूँ।
शार्ट में डॉक्टर साहब ने चर्चा की है और उनका सिर्फ एक ही मकसद है कि वो अपने शहर की, अपने देश की सेवा किस रूप में कर सके, उसी लक्ष्य को आगे लेकर ईवान हॉस्पिटल का जो आगाज़ किया हुआ है और उसमें जो खिदमत कर रहे हैं डॉक्टर साहब, तो ये कहीं ना कहीं आप शार्ट में पूरी देखेंगे वीडियो जिस तरीके से आज यहाँ पर एक संदेश गया है, एक मैसेज गया है। आप देखें कैमरामैन इमरान अंसारी के साथ अर्शद राना की अपना से एक खास रिपोर्ट।
We proudly can tell you we have saved 942 people's lives out there. Our doctors work day and night around the clock. Yes, I cannot please everybody. Nobody can please everybody. But when the pandemic hit, even in the United States, even the best to best doctor in the United States could not do what we did in Iran. I'm very proud of our team. So from that time on, now it was hard for me to build the doctor's team because everybody was saying to me, there's only one or two doctors, Dr. Jain, Dr. Pramod, Dr. Anubhav. So it was hard to bring doctors from outside to Iran. Finally, with Dr. Pankaj Jain and many others, we were proudly can tell you now 99% of the medical faculty we are having. Now we have a surgeon, we have orthopedic, we have gastro, we have general surgeon, we have everything at Iman. Our ICU working all the time, 24/7, our ICU work, CCU work, our OPD working, IPD working, you name it, everything working at Iman. And our satisfaction rate at Iman is 98.7. Again, some people have issues about financial issues, Ayushman issues, one or the other. I cannot satisfy everybody for their needs. But if I can satisfy 98.7% of the patient, I think it is the best thing that we can do at Iman. Again, we are looking to complete for betterment at Iman. That's why we have built the complete team. This is the first time in Iman history, from the time it was built till today, we have a full faculty of doctors. Now we are we are looking and we are extending to all the medical doctors in Muzaffarnagar to join us. There is one program that I launched now. We are inviting all the doctors to admit their patients. Anyone can admit their patients at Ivan. They will see the patient, they will discharge the patient, and the patient will be theirs. It will not be seen by anybody else, it will be seen by you only. And you are the only one who can discharge your patients. And whatever the compensation, whatever the service charges, it will be paid to you as per negotiation in a timely manner. So I think that's the best thing we can do to bring all the doctors in Muzaffarnagar. Instead of sending your patients from Meerut to Delhi, you can bring it to Ivan, and we will take care of them. And we will give them the best service that possibly they can get at Meerut or Delhi. Besides that, I think now only one faculty we are having, that anesthetic doctor, and hopefully we will be getting him within a couple of weeks. So gynae we have, orthopedic we have, neuro we have, pulmo we have, and in internal medicine, Dr. Pankaj Jain is there. So I think we have completed the dream, Dr. R.B. Singh, Dr. Pankaj Jain, Dr. Prana, Hardesh, and all the other doctors have seen at Iman. With that, I would like to invite each and every one of you to support Iman. Iman is the only hospital in Muzaffarnagar that can take care 24/7 your emergency, ICU, CCU. We have our best cath lab for the cardio. 24/7 Dr. Bhora is available. Dr. R.B. Singh also doing OPD at Ivan. So 24/7 your cardio patients will be taken care. And we have the best cath lab in this market. We have the top quality Philips cath lab. In addition to, we have CT scan and all the other best instruments that Philips company has to offer. So looking forward you to support Ivan 24/7, and we are here to take care of every patient with the full satisfaction to their need. Thank you very much. Appreciate it.
Works hard their precious time and come here to make the CMA success. And I would also like to thank Dr. Pankaj Jain and Mr. Vijay Jain and the IMM Muzaffarnagar for giving me the opportunity to introduce myself to the people of IMM Muzaffarnagar. And yes, the evening demands me to discuss something about the topic, so I'll be discussing something on endoscopic spine surgery. And I'm sure many of you must be knowing a lot about endoscopic spine surgeries because it is the need of the hour today. Now, we all know that before the advent of endoscopic spine surgeries, the open surgeries were done at most of the places. And the complications associated with open surgeries were basically what led to the development of endoscopic and keyhole that is. So, we all know because of
Rishikesh has got a special interest in obstructive sleep apnea, and he is proposing that, and will soon set up a sleep lab in Ivan also. So,
thank you, Pankaj sir, and good evening, everyone. Myself, Dr. Rishikesh Meena. I did my MBBS and MD from BHU, and then after I did my senior residency from AIIMS Bhopal. Actually, we have a plan to develop a complete pulmonary unit in Ivan Hospital with modern or advanced procedure as well as IPD, OPD and ICU. Basically, I did duties regularly in respiratory ICU and critical care medicine of AIIMS Bhopal. On the basis of these knowledge, we have planning for a well settled sleep lab and bronchoscopy as well as thoracoscopy in coming time. And actually, I would like to talk on a small talk on obstructive sleep apnea, which is a common problem but very neglected. एक्चुअली में कोई भी उस चीज़ पे ध्यान देते नहीं है कि कितना एक एक्चुअली में जनरल पॉपुलेशन में एक ओएस है और स्नोरिंग है, उसको एक जस्ट एक कॉमन प्रॉब्लम मानकर उसको नेग्लेक्ट करते हैं. उस पर मैनी डॉक्टर्स भी उस चीज़ पे ध्यान नहीं देते और ना ही सिम्टम पे ध्यान देते हैं. अभी रिसेंटली अराउंड 27 February my one of the big paper around 514 individuals on sex differences in view of symptoms of diagnosed OSA patient was published in Lung India. That was a very good paper and you can easily access freely. So usually many patients with obstructive pulmonary disease and other cardiovascular disease and diabetes, hypothyroidism, all disease have many times of prevalence in view of OSA, and the consequences of OSA is around in view of accidental cases around 4 to 6 times cases of increase in OSA patient. That was a very big data, and many patients around COPD, like COPD patient or asthmatic patient, but mainly in COPD patient, the OSA prevalence is very high than a normal population. We also conduct a study around 1,500 patients in AIIMS Bhopal that was in recently coming time published. That was many parameters we found that was neglected, especially in female patients, because female patients are hides their symptoms and doesn't speak, yeah, don't speak in front of doctors in many symptoms like snoring, morning headache, and एक सुबह के टाइम की मुझे फ्रेशनेस फील नहीं होता, एंड मल्टीपल एपिसोड्स ऑफ यूरिनेशन इन नाइट टाइम विदाउट एनी डिजीज. That was we are all most of peoples are missed in OPD time, because we are thinking about general population, general symptoms or constitutional symptoms, and we escape the OSA, क्योंकि many patients have many sleep disordered breathing, like NREM related disorders, REM related disorders, parasomnias, insomnias. So we have a plan for develop sleep lab in Ivan Hospital, as well as we are in nearby time going to many procedures like bronchoscopy guided many procedures like biopsy and brushing, bowel fluid, everything, and we are going to start thoracoscopy in nearby time. So I need your supports, Nivan. So thank you so much.
A very common topic covering very common problems we face in our clinical practice. So I will not go into the details of every problem, but I will tell you the problem and what can be done immediately so that we can provide first aid immediately. So first problem we face in clinical practice mostly by the surgeons, intraoperative or perioperative, hypotension. Hypotension, if hypotension occurs, anesthetist become panicky, surgeon become panicky, and whole OT become panicky. You know, first we have to rule out many things clinically. Patient is not hypovolemic, but the main cause of hypotension during intraoperative or perioperative period is pulmonary embolism, which is the least neglected and least thinkable cause at that time. So how to deal with it? It can present as a chest pain or hypoxia, and diagnosis is by simple D-dimer test, which can tell you that it is low probability cause or high probability cause or intermediate probability cause, or ECG, ABG will depict hypoxia. There will be no hypercapnia, only hypoxia, and CT pulmonary angio. So treatment depends whether patient is hemodynamically stable or unstable. Unstable means patient is in shock. Hypotension means shock, you can say that, but first you try to relieve the hypotension by giving fluids, inotropes. If it is not, then we should go for these anticoagulants or even surgical lysis of the clot by the catheter induced or mechanical. Or if patient is having recurrent embolism, then we can plan out the IVC filter, which can be either of two types, whether it is retrievable or irretrievable. It depends. In young patients, you can go for a retrievable IVC filter, which can be retrieved after 3 months or 6 months. And second problem we face is hypertension. Hypertension can, as everybody knows, it can present a headache, chest pain, shortness of breath, nocturia, and it is diagnosed by ECG, echo, RFT, and other test. And the main things we miss in treating the hypertension is diuretics. We keep on adding the beta blockers, calcium channel blockers, ACE inhibitors, but we forget to add diuretics. Diuretic is the backbone of the treatment for hypertension. Chest pain can occur. For chest pain, we have to find out whether it is a typical chest pain or atypical chest pain. You know, we have to differentiate clinically. And why I am telling these problems, because these all problems can be tackled on mobile. If you are not having a cardiologist physically at your site, you can contact the cardiologist over telephone, and he can guide you the treatment, the diagnosis, and further management. Gold standard, of course, is angiography, but we are not very keen for angioplasty in patient going for non-cardiac surgeries, because you know, if we put drug-eluting stent, then the surgery has to postpone for 12 months. For bare metal stent, we have to postpone the surgeries for 6 months. And this is a very common problem which is encountered by the anesthetist during intraoperative or post-operative period of palpitations. It is a very complex problem, but we can find out very easy solution. You know, first you have to decide whether it is a regular or irregular. It is in ECG whether it is a narrow QRS tachycardia or wide QRS tachycardia. You know, every topic is a full topic. Every line has got full topic. Though I'm not discussing in detail. You know, but the most important thing is whether patient is hemodynamically unstable or stable. Unstable means angina, dyspnea, hypotension, giddiness. Then treatment is DC shock, irrespective of whether it is a narrow QRS tachycardia, whether it is a wide QRS tachycardia, whether it is a regular or irregular tachycardia. You know, it doesn't matter. It doesn't matter. If patient is unstable, give the shock. Instead of calling the cardiologist, instead of calling the physician, oh sir, there is one patient who is collapsing, what shall I do? Give the shock. Shock. No, nothing. And if it is stable, then consult the cardiologist. He can guide you over the treatment. You know, and the most, it is a very common problem encountered in the surgical setup. When to stop aspirin, when to stop anticoagulants, patients who are taking these two drugs. You know, the rule of thumb is every drug has to be stopped after its 5 half-lives. Usually it takes 5 half-lives to clean up the drug from the body. So you should know the half-life of the drug and then multiply by 5. For that time you have to stop the drug. Aspirin, it is usually 7 days because platelets half-life are 7 days. But you can easily stop for 3 to 5 days, then you can do the surgery. And for warfarin, you have to stop for 40 hours, means 200 hours, almost 8 days. Apixaban, it is 12 hours, means 60 hours, means 2.5 days. Similarly for every drug. And for heparin, it is only 1.5 hours, means 8 hours. After 8 hours of stopping heparin, you can do the surgery safely. And for low molecular weight heparin, you have to stop for almost 1 day before surgery. You know, some situation become very complex. If patient is having wall replaced, then you cannot stop the anticoagulant completely, because you know, otherwise wall will get stuck. There will be thrombus on the wall. In those situations, you have to compromise. You don't have to compromise regarding the anticoagulants. You can stop the anticoagulant, but you have to start the heparin so that you can stop heparin before surgery. And just immediately after surgery, you have to again restart the things. And another problem encountered is DVT. DVT usually present with chest, cough pain, swelling, or even pulmonary embolism. You know, its diagnosis is venous Doppler. Treatment is medical, sometimes mechanical like stockings, pneumatic compressive devices, or even AV foot power pump, or surgical. We have to put IVC filter if there is a high risk for pulmonary embolism, and aim for PT INR is between 2 to 2.5, and duration of anticoagulants is usually 3 months. And if you've got any problem regarding cardiology, regarding these problems in your clinical practice, we can solve these problems over mobile also. You need not to send the patient to us. If you send the TCG and the vitals, we can always solve these problems telephonically. Thank you.
And extensive surgeries under GA and other anesthesia. So we needed something that could help them, that could take care of the things like back pain and other which degenerative spine diseases that they develop, and therefore we came up with minimally invasive spine surgeries and endoscopic spine surgeries because they can be done in less amount of time, and like in endoscopic spine surgery we can do that in local anesthesia also. So the PAC workup is not very important, and the post-op care is also very easy because patient the surgery itself takes around 30 to 60 minutes, and patient can be discharged same day, and he or she can carry on with their work. So yes, the early spine surgery has various complications like CSF leak, and one of the major complications was development of instability in the adjoining segments of the surgery because of the dissection. A lot of muscular and capsular dissection used to take place, which led to development of instability in post-op. So in order to avoid that, we came up with minimally invasive spine surgeries where very small incision was given, and instead of muscle cutting, we started doing muscle splitting surgeries, and the care was specially taken not to injure the capsular ligaments in order to avoid instability. So we came up with MIS, but still MIS was not very helpful in patients who were having a lot of medical comorbidities because these patients also needed either GA or local spinal anesthesia. So something was lacking. So because of that, the endoscopic spine surgeries came in, and we started doing endoscopic spine surgeries in local anesthesia. So it is just like, so we can say that it is a type of block that we give, but a major block because we introduce local anesthesia into the deeper place also, and then a very small incision of say what 10 to 11 mm is more than enough to do the surgery, and patient can start working after 2-3 hours and can be discharged by the evening or next morning. Now, as you can see, this is one of the complications which led to the development of C6-7 instability because all the segments from C2 to C6 are fused, and the only place where the mobility could take place was the C1, C2 joint and the C6-7 joint. So all the load came up to C6-7 joint, and patient developed instability. One of the major reasons of development of instability is dissected out while doing open surgeries. This is also one of the example where there is listhesis of L3 over L4. We can see that this fixation was done in L5-S1, and the listhesis got developed of L3 and L4 in the post. So that could be only possible because the patient underwent open surgery and there was damage to the ligaments and the posterior ligamental complex. So these things can be avoided while doing minimally invasive surgeries and endoscopic. In minimally invasive spine surgeries, where a tubular retractor was used to do the facetectomies, like it can be used in various procedures like decompression of spine, and discectomies, in doing body fusions like T-leaf and O-leaf. Now, the basic concept of endoscopic spine surgeries is the identification of Cambrian's triangle. The floor is formed by the end plate of the lower vertebra, and the height is formed by the either we can say the traversing nerve root or the superior articular facet of the inferior. One is to the exiting nerve root that can happen if you do not orient the endoscope properly. So the only thing we have to do is, the most important thing rather is that we need to find this triangle because it is very hard. So the aim is only to direct the needle, because in endoscopic spine surgeries, what we do is we first insert a needle, we give the local anesthesia, and then we slowly dilate the tract. After dilating, then we put the endoscope and do the surgery. So most important step is putting the needle. If we have placed the needle in the Cambrian's triangle and it is at the right place, then the surgery is a KO. As you can see here, the incision is a bit lateral, yes of course, and then because in order to achieve the trajectory towards the foramen, we need to go a bit lateral. And here we can see that the endoscope is going, it is going through the Cambrian's triangle just below the exiting nerve root, and we can remove the disc which is causing compression over the exiting nerve root. Now this is the cross section of the endoscope that we use. It's a uniportal kind of surgery. We have a working channel, irrigation channel, a light source and camera, or everything is in a single port. Yes, the tubular retractor. One of the major thing with the tubular retractors was that we needed microscopes. With the advent of endoscopic surgeries, the use of microscope is less because we do not. Which was, you can say, if you say someone that you need a spine surgery, say 10 years back, that patient used to have night terrors because getting a spine open, people used to say that yes, paraplegia. The relatives used to counsel the patient, but now we do not need to worry about these things. And it has become safe, painless, and the goal, this is the goal, the minimally invasiveness is what we need. And yes, we do not have any scar and people can return to their work from next day only. These are the approaches that we use transforaminal, internal minor, different approaches for different areas of the disc that we need to remove. And with the development of technology also, now we can also do fixation by endoscopy. Spine fixations can also be done, and decompression of spine also. Now, this is one of the example where we have a tubular retractor which is showing the anatomy of